What if I told you that every action of motion and movement in the body is performed by muscles? Today we'll be talking about the muscles of the pectoral region and the anatomy of the pectoral region. In medicine, confusion costs marks and mistakes cost lives. Stop memorizing, start understanding. This is Dr. ABM, where medicine finally makes sense. Let's get right in. So today we'll be looking at the concept of the pectoral region. The pectoral region. So the pectoral region is the anatomical area that is found on the chest wall. It forms the junction between the axial skeleton and the appendicular or the upper limbs. The pectoral region is made up of muscles that connect the thoracic wall and the humerus and scapula, and is very, very important in movement, in upper limb movement. So the boundaries of the pectoralis or the pectoral region is bounded superiorly. So the pectoral region is bounded superiorly by the clavicle. Inferiorly is bounded by the sixth rib. So if you count the rib, you have 1, 2, 3, 4, 5, 6, 7. So the sixth rib, right, is the lower border. Then medially it is bounded by the sternum, and laterally it is bounded by the axilla. Now the pectoral region is made up of layers. The most superficial layer is the skin. Below the skin is the superficial fascia. Below the superficial fascia you have the deep fascia. Below the deep fascia you have muscles. Below the muscles you have the clavipectoral fascia. And deep inside you have the neurovascular bundles. So what are the muscles of the pectoral region? The muscles of the pectoral region are divided into superficial muscles and deep muscles. Superficial muscles are, number 1, the pectoralis major. This muscle you can see right here is the pectoralis major. The pectoralis major. Then we have the pectoralis minor, the subclavius, and then the deep muscle is the serratus anterior. First off, we'll talk about the anatomy of the pectoralis major. Now, this pectoralis major is a large fan-shaped muscle that forms the bulk of the anterior chest wall. The origin is from the medial half of the clavicle, and then it inserts into the intertubercular sulcus. So this is the insertion, and this is the origin. The half on the clavicle or the clavicular end, and then it inserts into the humerus, the intertubercular sulcus. Now it is innervated by two nerves. You have the medial pectoral nerve and the lateral pectoral nerve. Medial pectoral nerve is CA to T1. Lateral pectoral nerve is C5 to C7. Now what is the action and the function of this muscle? The first job is that it is an adductor, adductor. So it brings the arm or the upper limb closer. So it moves the upper limb like this, right? It is also a medial rotator and a flexor. Very important. It's used in weightlifting and also used in reconstructive surgery. The next muscle just below it is the pectoralis minor. So you're looking at the pectoralis minor here. This is the pectoralis minor. It's actually a thin triangular muscle that lies below the pectoralis major. So it originates from the ribs. So this is the origin, the 3rd, 4th, and 5th rib. And then it inserts into the superior surface or the coracoid process. So originates here, inserts here. It is innervated by the medial pectoral nerve, CA to T1. And then its function is to stabilize the scapula, and it can also act as an accessory muscle of inspiration. It's actually, clinical correlate is involved in thoracic outlet syndrome. So that's the anatomy of the pectoralis minor. Moving on, this is a triangular muscle. It's a small cylindrical muscle. Not triangular, it's a small cylindrical muscle that lies beneath or under the clavicle. So sub, below, clavicle, clavius, subclavius. So usually it originates from the first rib here, and then it inserts into the middle third of the clavicle, around into the third of the clavicle. The innervation is by the nerve to the subclavius, which is C5 to C6, and then the function is it helps to stabilize the clavicle. That's the function. Then it can also protect the vessels around there. So that's the anatomy of the subclavius. Next up is the serratus anterior. So this is the serratus anterior muscle. It's a large flat muscle on the lateral thoracic wall. It originates usually from the ribs, usually the first 1 to 8 ribs, and then inserts into the scapula. It inserts into the scapula around the back region here. It's innervated by the long thoracic nerve, that's the innervation, C5 to C7, and its action is to protract the scapula. It moves the scapula forward, and it helps to do upward rotation of the scapula. The clinical correlate is in the case of long thoracic injury. Long thoracic injury causes winged scapula. Don't forget that. Long thoracic nerve injury causes winged scapula, and it results in difficulty raising the arm above 90 degrees because the serratus anterior helps in that function. Take note. Now, the clavipectoral fascia is a strong fascia that is found in the pectoral region, and it is pierced by three structures. First is the cephalic vein, second is the thoracoacromial artery, third is the lateral pectoral nerve. You might need to go over that again. Now, the blood supply of the pectoral region is by the pectoral branch of the thoracoacromial artery, the lateral thoracic artery, and the internal thoracic artery, while the venous drainage is by the axillary vein. Remember that the clinical correlate of the pectoral region is in the case of winged scapula, damage to the long thoracic nerve, which results in serratus anterior paralysis. There's also pectoral nerve injury, where there's weakness of adduction, there's thoracic outlet syndrome. Moving on, we quickly talk about the anatomy of the breast. The breast, also called the mammary gland, and is a modified sweat gland that is located in the superficial fascia of the pectoral region. It is present in both sexes, but is rudimentary and non-functional in men, but is fully functionally developed in females for lactation. Now, the breast extends vertically from the second to the sixth rib, and horizontally from the lateral border of the sternum to the mid-axillary line. The breast lies over the pectoralis major, two-thirds of it, and then the remaining part is over the serratus anterior. And it extends into the axilla. This part that extends into the axilla, we call it the axillary tail or the tail of Spence. Now, describing the external features of the breast, you have the nipple that is located on the fourth intercostal space in nulliparous females. It contains the openings of the lactiferous ducts. And then the areola, right? They are pigmented area that surrounds the nipple, and they contain sebaceous glands. Take note that the sebaceous glands here are called Montgomery glands. So, the breast is made up of, the structure of the breast involves first the skin. Below you have the superficial fascia that contain fats, vessels, and nerves. Then you have the glandular tissue that is made up of lobes. Each of those lobes drain into a lactiferous ducts, and those lactiferous ducts are found just below this areola. And then you have fibrous tissue. Take note that the fibrous tissue that connects the breast to the skin is called the suspensory ligament or the Cooper's ligament. It helps to maintain the shape of the breast. Then you have the retromammary space, which allows for mobility. It allows for mobility of the breast and is the site of surgical dissection. Now, microscopically, the breast is made up of lobes inside. Each lobes break down to form lobus, and each lobus form alveoli. The alveoli are lined by secretory epithelial cells and myoepithelial cells that help to push milk out during milk ejection. Now, the blood supply of the breast is by the internal thoracic artery, lateral thoracic artery, thoracoacromial artery, posterior intercostal arteries. Those are the four blood vessels that supply the heart, while the venous drainage is by the axillary vein and the internal thoracic vein. Now, the lymphatic drainage is very important. Now, approximately 75% of breast fluids or lymph drain into the axillary lymph nodes. So, the axillary nodes you have are, we use PCA, pectoral, central, and apical. The remaining drainage drain into the parasternal nodes opposite breast and the inferior phrenic nodes. So, the lymph nodes you have the apical, you have the central, and you have the pectoral. Then these are the axillary, lateral axillary, subscapular, anterior axillary, paramammary, parasternal, submammary. Of all of these, the first three you must remember: apical, central, and pectoral. Now, the nerve supplied to the breast is by the intercostal nerve, the second to the sixth intercostal nerve. Take note that breast has no motor innervation and lactation is hormonally controlled. Remember that the breast develops from the mammary ridge, and the hormone that is responsible for milk production is prolactin, while the hormone responsible for milk ejection is oxytocin. Applied anatomy of the breast, you have breast cancer or breast carcinoma, which usually occur on the upper outer quadrant. The signs of breast cancer are: you have pupil orange, nipple retraction, and skin dimpling. Other clinical correlates involve mastitis, inflammation, mastectomy, surgical removal of the breast. Mammography is a screening tool that is used to detect any issue with the breast. The breast quadrants are divided into 4: upper, outer, upper inner, lower outer, lower inner. Those are the breast quadrants. And then polytelia means more than one nipple. More than one nipple. While polymesia means multiple breast. Multiple breast. So this is the anatomy of the breast. Back muscles. Now the back is the region that extends from the base of the skull to the gluteal region. And laterally it extends to the posterior axillary border and it forms the posterior aspect of the trunk. Usually it helps in protection of the spinal cord as site for attachment of muscles and for support. So the boundaries of the back we have is superiorly it is bounded by the external occipital protuberance, inferiorly by the iliac crest, laterally by the posterior axillary lines, and then medially by the vertebral column. The back has layers. First, skin. All the layers are always like that. Skin, below it superficial fascia, deep fascia. The deep fascia of the back is known as the thoracolumbar fascia. Then below it is muscles, below it is vertebral column, spinal cord, and then meninges. Now the muscles of the back are classified into extrinsic and intrinsic. The extrinsic are the ones that connect the upper limb to the trunk, while the intrinsic, which are the true back muscles, maintain posture. So quickly let's run through the extrinsic muscle. The first one we have is the trapezius. So this is the trapezius here. The trapezius. The trapezius looks like a trapezium shape, hence the name trapezius. It originates from the external occipital protuberance or the superior nuchal line and inserts into the clavicle. It inserts into the clavicle and the spine of the scapula and a part into the acromion. The trapezius is innervated by cranial nerve 11, which is the spinal accessory nerve for motor functions, while the sensory is by C3 to C4. Primary function of the trapezius is for elevation. It plays a role in retraction, depression, and upward rotation of the scapula. It helps to raise the shoulder above 90 degrees. An injury to the trapezius causes shoulder drooping. Shoulder drooping. Take note. Next, latissimus dorsi. So this is the latissimus dorsi. Latissimus dorsi originates from the spinous process, T6 to T12. A part of it from the iliac crest, a part of it from the ribs, the 3 to 4 ribs, and then it inserts into the intertubercular sulcus of the humerus. So it inserts here. It's innervated by the thoracodorsal nerve, C6 to C8, and its function is to extend and to adduct. It also plays a role in medial rotation of the arm. Now, injury or paralysis of the latissimus dorsi results in difficulty in climbing. Difficulty in climbing. And the latissimus dorsi is also regarded as the swimmer's muscle. That's because it helps in extending the arm and also help in adduction and medial rotation. It's seen here. It originates from the transverse process of C1 to C3 and then it's inserted into the scapula, the medial border, superior medial border of the scapula. Levator scapulae is innervated by the dorsal scapular nerve, C5, and the function is elevating the scapula. Elevator of the scapula. Next up, we have the rhomboid major and the minor. Rhomboid major and minor. They originate from C7 to T5 of the spinous process and insert again into the scapula, the medial border of the scapula. They are innervated by the dorsal scapular nerve and they function in retracting the scapula. Now, all these muscles are superficial muscles of the extrinsic muscles of the back. Then the ones that are intermediate are the serratus muscles. You have the serratus posterior superior and the serratus posterior inferior. The serratus superior elevates the ribs while the serratus posterior inferior depresses the ribs. They are both innervated by the intercostal nerves. Moving on quickly, we discuss the intrinsic muscles of the back. Now, the intrinsic muscles of the back are enclosed deep by the thoracolumbar fascia, and they include the splenius capitis, which extend and rotate the head. Right here, extend and rotate the head. It inserts into the mastoid process that originates from the ligamentum nuchae. Then you have others. So you have the splenius cervicis that extend the neck. So splenius capitis extend the head. Same thing with splenius cervicis, extend the neck. Cervicis extend the neck, capitis extend the head. Then you have the erector spinae group of muscles, which include the iliocostalis, the longissimus thoracis, and the spinalis muscle thoracis. They have a common origin from the iliac crest and the spinous process, and they insert in the ribs. They are innervated by the spinal nerves, the posterior of the spinal nerves, and their function is in extending the vertebral column. Then you have other groups of muscles known as the transversus spinalis group of muscles. These muscles include the semispinalis capitis muscle, semispinalis cervicis. You have the montifudus and the rectatoris. Their function is to stabilize the vertebral column. Other muscles that are deep in the back are the interspinalis, the intertransversarii, and the levatores costarum. These are the muscles of the back. Now, the blood supply of the back is by the posterior intercostal arteries, lumbar arteries, and subclavian branches, while the venous drainage is drained by the azygos system. Clinical anatomy include back strain as a result of erector spinae injury. Scoliosis is abnormal curvature of the back due to trauma. Nerve compression results in disc prolapse. Trapezius paralysis as a result of accessory nerve injury, and others. We'll talk about the anatomy of the axilla. Now, the axilla is a pyramidal fat-filled space that is located between the upper limb and the thoracic wall. It actually serves as a passageway for neurovascular bundles and helps to transmit these neurovascular bundles to the upper limbs. The axilla is very important and is shaped like a pyramid. The apex is directed towards the root of the neck, and the base is made of the skin and the fascia of the armpit. Now, the boundaries of the axilla that you have is the apex is formed by the clavicle, so you can see the apex here, the clavicle, and then medially by the first rib, right? And then the base. Now, in the apex, you have the axillary vessels and the brachial plexus. The base is formed by the skin and the superficial fascia. The anterior wall is formed by the pectoralis major, pectoralis minor, and the subclavius. It's formed by the pectoral muscles, while the posterior wall at the back is formed by the subscapularis and the teres major. The medial wall is formed by the serratus anterior, medially, and then the lateral wall is formed by the intertubercular sulcus of the humerus. Now, the content of the axilla. So this is laterally, again, by the intertubercular sulcus, posteriorly, medially, anteriorly. So take note. Now, the content of the axilla are: number one, the axillary artery, the axillary vein, the brachial plexus, the axillary lymph nodes, and fats. So axillary artery, vein, lymph nodes, and the brachial plexus. Quickly, let's talk about the muscles of the axilla. You have the anterior wall muscles, which are the pectoralis major, pectoralis minor, subclavius, while the posterior wall muscle is made of the subscapularis, the teres major, the latissimus dorsi. The medial wall is made up of the serratus anterior. Take note. Those are the muscles in the axilla. Now, the axilla is made up of neurovascular bundles, of which the first is the axillary artery. Now, the axillary artery is divided into three parts by the pectoralis minor. Take note, pectoralis minor, not pectoralis major. By the pectoralis minor. It's divided into a first part, a second part, and a third part. The first part has one branch, the second part has two branches, while the third part has three branches. The first part is the superior thoracic artery, second part is the thoracoacromial artery and the lateral thoracic artery, third part is the subscapular artery and the anterior and posterior circumflex humeral artery. Now, the axillary vein returns blood out of the axilla. It's a continuation of the basilic vein, and as it progresses, it becomes the subclavian vein. The subclavian vein. Take note. The axillary lymph nodes are the pectoral lymph nodes, subscapular lymph nodes, humeral lymph nodes, central and apical. Now, the clinical correlate of the axilla is lymphadenopathy, axillary lymphadenopathy, as a result of metastasis of cancerous cells. A surgical neck fracture of the head of the humerus will cause axillary nerve injury, and then brachial plexus block. These are clinical correlates of the axilla. Moving on, we quickly talk about the scapulohumeral muscles. Now, the scapulohumeral muscles, from the word scapula and humerus, are muscles that originate from the scapula. They originate from the scapula, and then they insert into the humerus. They act primarily on the glenohumeral joint, and they produce movement of the arm. Now, these muscles include the deltoid, the teres major, the supraspinatus, infraspinatus, teres minor, and the subscapularis. The last four are called the rotator cuff muscles. Remember, they are generally for stabilization of the glenohumeral joint. They also act as a medial and lateral rotator and for arm abduction. Let's get right into it quickly. The first one we look at is the deltoid muscle. This is the deltoid muscle. The deltoid muscle originates from the spine of the scapula, also from the acromion and a part of the clavicle. Then it inserts into the humerus, into the deltoid tuberosity of the humerus. The deltoid muscle is innervated by the axillary nerve. Axillary nerve is C5 to 6, and the function of the deltoid muscle is for abduction. Abduction 15 degree to 90 degree. 15 degree to 90 degree. Take note. Remember that abduction is first from 0 to 15 degree by the supraspinatus, 15 to 90 degree by the deltoid muscle, and above 90 by the trapezius and the serratus anterior. Don't forget that. Now, clinical correlate of the deltoid muscle is surgical neck fracture. If there's a fracture of the neck of the humerus, it causes axillary nerve injury, and that leads to the flattened shoulder contour. Move out the teres major. Now, this is the teres major muscle. Teres major. It originates from the scapula, usually at the inferior angle of the scapula here, and then it inserts into the humerus, the intertubercular sulcus of the humerus. It is innervated by the lower subscapular nerve, C5 to 6, and its function is adduction. So it adducts and medially rotates. So it brings the arm like this, closer. It adducts and medially rotates. Now, the next group of muscles are the rotator cuff muscles. We call them SITS muscle, SITS. This means supraspinatus, I is infraspinatus, T is teres minor, and S is subscapularis. Let's look at them quickly. The supraspinatus. This is the supraspinatus. It's found in the supraspinous fossa where it originates, and then it inserts into the humerus, the greater tubercle. It is innervated by the suprascapular nerve, which is C5 to 6, and it functions as initial abductor, abductor, for the first 15 degree. So it is responsible for moving the hand or the upper limb 15 degree from here to here a little bit, and then deltoid will move it from 15 straight to 90, and then trapezius and serratus anterior will move it from 90 above. Don't forget the abductors. Alright, the clinical correlate is common tear. Then moving on, we'll discuss the infraspinatus. Infraspinatus is found in the infraspinous fossa of the scapula where it originates, and it inserts into the greater tubercle of the humerus. It is also innervated by the suprascapular nerve, C5 to 6, and it functions as a lateral rotator. We talk about the teres minor. Teres minor originates in the scapula and inserts in the greater tubercle of the humerus, innervated by the axillary nerve, C5 to 6, and functions as a lateral rotator. Then you have the subscapularis. The subscapularis is found in the subscapular fossa. It inserts into the humerus, is innervated by the upper and lower subscapular nerves, C5 to C7, and its action is a medial rotator. Again, don't forget the mechanism of abduction. 0 to 15 degree by supraspinatus, 15 to 90 degree by deltoid, above 90 trapezius and serratus anterior. So the rotator cuff muscles are responsible for stability of the glenohumeral joint. The clinical correlate is common rotator cuff tear, and shoulder dislocation is mostly in the inferior aspect, the anterior inferior aspect. Then axillary nerve injury. The muscles of the arm. Now, the arm is also called the brachium, and it extends from the teres major to the elbow joint. It is divided into two compartments by a medial and lateral intermuscular septum. The anterior and the posterior compartment. Now, take note that the anterior compartments are flexor compartments, while the posterior compartments are extensor compartments. Very, very important. So, anterior, flexors of the joint below. So, flexors of the elbow joint. Posterior, extensors. Just take note. So, let's quickly look at the anterior compartment. The anterior compartment, the flexor muscles are the biceps brachii, the brachialis and the coracobrachialis. All of them are innervated by musculocutaneous nerve. Musculocutaneous nerve is C5 to C7. Firstly, we look at the biceps brachii. This biceps brachii. Bi means two. So it has two heads, a long head and a short head. The long head originates from the supraglenoid tubercle, while the short head originates from the coracoid process. They both insert into the radial tuberosity. They are all innervated, all anterior muscles are innervated by the musculocutaneous nerve, and they primarily do the function of supination. So biceps brachii is a supinator. The brachialis originates from the humerus and it inserts into the coronoid process of the ulna. Also innervated by the musculocutaneous nerve and is a flexor of the elbow. The coracobrachialis originates from the coracoid process and inserts in the humerus, innervated by the musculocutaneous nerve and is a flexor and adductor. Take note that all anterior compartment muscles of the arm are flexors. Moving on, we go to the posterior compartment. Remember what we said about the posterior compartment, that they are extensor muscles, right? And these posterior muscles are innervated by the radial nerve. Radial nerve is C6 to C8. The muscles are the triceps brachii and the anconeus. Now the triceps brachii, triceps, it has three heads, It has a long head, a lateral head, and a medial head. Long head originates from the infraglenoid tubercle, the lateral and the medial head from the humerus, from the posterior humerus, above the radial groove. And then they all insert into the ulna, the olecranon of the ulna, innervated by the radial nerve, C6 to C8, and they are extensor muscles, extensor. The inner correlate of the triceps is when there is a radial nerve injury. There's a shaft fracture of the humerus. It causes radial nerve injury. Next one is the anconeus. The anconeus is a small muscle at the lateral epicondyle of the humerus and inserted into the olecranon too. It just assists in extension. So these are the muscles of the arm. Moving on, cubital fossa is a triangular depression on the anterior aspect of the elbow. It's the middle portion between the arm and the forearm, and it's a very, very important site. Now the cubital fossa is triangular in shape, so you can see it triangular in shape. The superior part is formed by the epicondyles. The medial boundary is formed by the pronator teres medially, so this is medially. The lateral border is by the brachioradialis laterally. The floor is by the brachialis. The brachialis forms the floor, and then the roof is by the skin. So the content of the cubital fossa is used MBBR. First is the medial nerve, medial nerve. Then you have the biceps tendon, you have the brachial artery, and you have the radial nerve. Don't forget MBBR. Medial nerve, biceps tendon, brachial artery, and the radial nerve. The clinical importance of the cubital fossa is for venopunction, where blood is taken in the median cubital vein. It's also for brachial pulse palpation in blood pressure measurements. And a supracondylar fracture results in injury to the brachial artery. The blood supply to the cubital fossa is by the brachial artery, the radial artery, and the ulnar artery. The nerve relations are the medial nerve and the radial nerve. We'll talk about the anatomy of the forearm. Now the forearm is the longest portion of the upper limb. It extends from the elbow to the wrist, and the muscles there are usually for movement of the wrist and the fingers. They are also for pronation and supination. Again, just like the arm, the forearm is divided by intermuscular septum into an anterior, which is a flexor or a pronator compartment, and the posterior, which is an extensor or supinator compartment. Let's get right into it. We'll start with the anterior compartment. That's the flexor pronator compartment. Now there are general features you should know. First one is that all the muscles are mainly innervated by the medial nerve, except for the flexor carpi ulnaris and the half portion of the flexor deuteron profundus. So flexor carpi ulnaris is the only anterior muscle that is innervated by the ulnar nerve, and a part of the flexor deuteron profundus. Take note. And then they all originate from the medial epicondyle. Hence, while the medial epicondyle of the humerus is known as the common flexor origin. So the muscles of the anterior compartment are divided into three layers: superficial, intermediate, and deep. The superficial layer include the pronator teres. Remember we said they all originate from the medial epicondyle, and then the pronator teres insert into the radius. Remember, innervation is by the medial nerve, and from the name pronator is for pronation. You have the flexor carpi ulnaris, flexor carpi radialis, not ulnaris, flexor carpi radialis, again, originate from the medial epicondyle, insert into the second and third metacarpals, innervated by the medial nerve, and flexor is the flexor carpi in the carpal, so it flexes the wrist because that's where you have the carpal bones. Then you have the palmaris longus. Palmaris longus, again, originate from the medial epicondyle, insert into the palmar aponeurosis, again, medial nerve, and is a weak flexor. Then the flexor carpi ulnaris now is the only one that's innervated completely by the ulnar nerve, again, originate from the medial epicondyle, insert into the carpals, and is a flexor. The intermediate muscles are the flexor deuteron superficialis, it's innervated by the medial nerve, originates from the medial epicondyle and insert into the phalanges, is a flexor, it flexes the PIP joint, proximal interphalangeal joints. Then the deep layers. You have the flexor deuteron profundus, the flexor pollicis longus, pronator quadratus. So remember, the flexor deuteron profundus originates from the ulna and insert into the phalanges. Now the flexor deuteron profundus has dual innervation, hence we say it's a dual muscle. It is innervated laterally by the medial nerve and medially by the ulnar nerve. It's a flexor muscle. It flexes. Flexor pollicis longus originates from the radius and inserts into the thumb. Pollicis means thumb. Pollicis. Innervated by the medial nerve and flexes the thumb. The pronator quadratus originates from the distal ulna, insert into the radius, and is innervated by the medial nerve. It's a pronator, the primary pronator, even more than pronator teres. Now, it's important to know that for the anterior compartment muscles, they are flexor pronators. All of them originate from the medial epicondyle. All of them are innervated by the medial nerve, except for flexor carpi ulnaris and a part, the medial part of the flexor deuteron profundus. Their function is gotten through their name. So pronator teres is a pronator. Flexor carpi ulnaris flexes the wrist, carpi. Palmaris longus is a flexor. Flexor carpi ulnaris flexes in the carpals. That's the wrist again. Then the intermediate one, which is flexor deuteron superficialis, is found superficial, is still a flexor. Flexor deuteron profundus is found deep, profundus. It flexes the digits, the second to fifth digit. Remember, the first one, which is the thumb, you will say pollicis. That's the function of the flexor pollicis longus. And then pronator, obviously, is going to pronate. The posterior compartment muscles of the forearm, remember, these are extensor and supinators. So general feature, all of them originate from the lateral epicondyle. Hence, where the lateral epicondyle of the humerus is called the common extensor origin. And they are all innervated by the radial nerve, C6 to C8. They are divided into superficial and deep. The superficial muscles include the extensor carpi radialis longus, extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum. They are all extensors, and all originate from the lateral epicondyle, and they insert into the digits. Extensor digiti minimi extends the little finger. Minimi is the little finger. Extensor carpi ulnaris extends the wrist. Extensor deuterum extends the digits. That's second, third, and fourth, and a little function on the fifth. Then the deep muscles. The deep muscles include the supinator, the abductor, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and extensor indicis. Remember, all these muscles are innervated by the radial nerve, usually the deep ones by the posterior interosseous nerve, a branch of the radial nerve. So the supinator is primarily for supination. I've told you the name is the function. Abductor pollicis longus is a long muscle that abducts the thumb. Extensor pollicis brevis is a short muscle that extends the thumb. Extensor pollicis longus is a long muscle that extends the thumb. Extensor indicis extends the index finger. Now this is the muscles of the forearms. Remember, anterior muscles by the medial nerve, except for the flexor carpi ulnaris and the medial part of the flexor deuteron profundus, while posterior muscles by the radial nerve. Very important. Now, the clinical correlate involves carpal tunnel syndrome, which causes medial nerve, which is as a result of medial nerve compression, ulnar nerve palsy, and radial nerve injury, which causes wrist dropping. Blood supply to the forearm is by the radial artery, ulnar artery, the anterior and posterior interosseous artery. The muscles of the hand. Now, the hand is the principal organ. The hand. This structure is the hand. For fine motor function, the muscles that are found in the hand allow gripping, precision gripping, opposition, and coordinated hand or digital movements. Now, the muscles in the hand are arranged into layers. You have the first one is called the thenar compartment. Thenar is the side of the thumb. So everything here in the thumb aspect, everything here is the thenar compartment. Everything here from here around is the thenar compartment. So here is the thenar compartment. Then hypothenar compartment is anything to the little finger here, hypothenar. And then you have the lumbricals and the interossei. So let's get right into the thenar muscles, the thumb muscles. So the muscles are abductor pollicis brevis, abductor, then flexor pollicis brevis, opponens pollicis, and adductor pollicis. Let's start with the abductor pollicis brevis. Abductor pollicis brevis. This muscle right here, abductor pollicis brevis. It originates from the flexor retinaculum and inserts into the thumb, the proximal phalanx of the thumb. It's innervated by the median nerve, and from the name, it's an abductor. It abducts the thumb. The next one is the flexor pollicis brevis. The flexor pollicis brevis is this muscle right here. Originates again from the flexor retinaculum, inserts again in the phalanx. It has dual innervation, very important. The superficial edge is by the median nerve, while the deep edge is by the ulnar nerve. So the flexor pollicis brevis is innervated by both median and ulnar nerve. From the name, it's a flexor. It flexes the thumb. Then you have the opponens pollicis. The opponens pollicis. The opponens pollicis is responsible for opposition, gripping of the thumb. Take note, is innervated by the median nerve. Then you have the adductor pollicis. Adductor pollicis. This muscle right here. It's innervated by the ulnar nerve. Ulnar nerve. Ulnar nerve. So all the muscles of the thenar compartment are innervated by the median nerve, except the opponents, the adductor pollicis. Except the adductor pollicis first, which is innervated by the ulnar nerve. Are we good? And then by the flexor pollicis brevis, which is innervated by both. Which is innervated by both median nerve and ulnar nerve. Keep that at the back of your mind. Next one, we move to the hypothenar muscles. The hypothenar muscles are the abductor digiti minimi, flexor digiti minimi brevis, opponens digiti minimi, and the palmaris brevis. The abductor digiti minimi originates from the pisiform and inserts into the phalanx of minimi, that's the last finger, and then function is abduction. The flexor digiti minimi brevis is a short muscle, originates from the armpit and inserts into the proximal phalanx, is also a flexor muscle. The opponens digiti minimi is responsible for opposition of the little finger, gripping action of the little finger, and then the palmaris brevis is for gripping function too. Now we have lumbricals, lumbrical muscles. Lumbrical muscles originate from tendons. They are very unique muscles. They originate from tendons of the flexor digitorum profundus and insert into the extensor expansion. Now there are 4 of them: first and second, third and fourth. Lumbrical 1 and 2. 1 and 2 is innervated by the median nerve, while 3 and 4 is innervated by the ulnar nerve. Don't forget 1 and 2 median, 3 and 4 ulnar. They are flexors at the metacarpophalangeal joint, and then they extend the interphalangeal joint. Don't forget that. Then you have the interossei muscles. The interossei muscles are divided into 2 groups. They are the palmar interossei, there are 3, and the dorsal interossei. All of them are innervated by the ulnar nerve. The palmar interossei is 3, the dorsal interossei is 4, but all of them are innervated by the ulnar nerve. The palmar interossei, now there's an acronym we call PAD-DAB. P-A-D, PAD, D-A-B, DAB. PAD means palmar adduct. So palmar interossei adducts. Then DAB, D-A-B means dorsal interossei, A-B, abducts. So the palmar interossei are responsible for adduction, while the dorsal interossei are responsible for abduction. Remember that the hand blood supply is by the superficial and the deep palmar arch, which are branches of the radial and ulnar arteries. The clinical correlates of these muscles are in median nerve injury as a result of seen in carpal tunnel syndrome, ulnar nerve injury which results in claw hand, Now, these are the muscles of the upper limbs. Now, that's how this concept should be understood. Clear, precise, and exam ready. If this helped you, go ahead, like the video, drop a comment, and tell me what topic you want next. This is Dr. ABM, where you don't just study medicine, you master it.